This conference will now be recorded.
So yes, today we will start our discussion with this talk that is cesarean Nikki. The cesarean nick, that is basically a cesarean scar defect. Okay, which is now. Can you see the screen? Yeah. Yeah. Okay. So according to the latest NHS survey, maternity survey, what they have found out is in UK cesarean section rate is currently around 30%. Okay, with wide variations in different age groups and different regions. On global scale, what WHO thinks is more than 10 to 15% of cesarean section days are unnecessary, but still in high income countries, they have increased rate of cesarean section like 32% in US, 41% in South America, 50% in China, and now in underdeveloped countries there is, I think, more the rate of cesarean section than these also. So cesarean nick, it is a scar defect at the site of hysterectomy. It can contribute. Am I audible? Hello.
Yes,
Yes,
ma'am.
ma'am, you're audible.
Yeah. Okay, Shaista, please log out and again log in. Okay, because my voice is audible to all others. Okay. So cesarean nick, it is a scar defect at the site of hysterectomy and it can contribute to various menstrual symptoms, okay, and also sometimes responsible for subfertility. So in this talk, what we are going to deal with is, or what they have dealt with in this talk is, what do you exactly mean by this cesarean nick, how you are going to diagnose it, what are the manifestations of it, and how to manage it. So, what is the responsible factors for this development of cesarean nick? So, because what happens at the scar site during healing, these are the changes which occurs in the scar site. So, it will be residual suture site, giant cell reaction, distortion and anatomical widening of the lower segment, capillary remodeling, and immune reaction, which is marked by infiltration of lymphocytes into the uterine scar. Shaista, please log out. 1 minute, I will send her message. So these are the changes which occur during healing at the place of cesarean scar. So also other pathological changes which can occur at the scar site is congestion of endometrium and polypoidal reaction. Again, what it is proposed is that there will be lack of coordinated muscular contraction around the cesarean scar that will cause this menstrual debris to collect in that scar defect, which will result in persistent spotting after cessation of menstrual bleeding. So this can be a troublesome symptom after a cesarean scar. Okay. So most common thing which occurs during healing is the giant cell reaction. Okay, residual suture with giant cell reaction, which happens in around 92% of cases. So what do you mean by cesarean nick? So other names for it is cesarean scar defect, isthmosil, post-cesarean section scar defect, cesarean nick, cesarean delivery scar pouch. These all words are synonyms to each other. So it is commonly identified on ultrasound by a hypoechoic area in the anterior lower segment, which represents a defect in the myometrium because of poor healing. So it can appear in different shapes and size, but usually it is triangular or semicircular areas. This defect is more commonly occurred when the cesarean section is performed in advanced labor, that is more than 5 hours of active labor and more than 5 centimeters of dilatation. So this causes larger defects because of lower incision and overall more complicated surgery, which also retards the healing process. Also, there is direct correlation between the number of cesarean section and the size of defect. Why? Because there will be retroflexion of uterus. Okay, so what happens because of number of cesarean section, it increases the adhesion formation, and because of that adhesion formation, there will be traction while healing on that scar, and it pulls the uterus in opposite direction, and it causes the retroflexion. So what are the risk factors for this nick development or defect development is the closure technique, location of the incision, wound healing, and other factors. So when we consider the closure of the technique, okay, so or closure of the incision or closure technique. So if the incision is inappropriately low in the uterine segment, lower uterine segment, if we do a aggressive bladder reflection, or sometimes in the advanced labor, we can do incision which is lower in the lower uterine segment. So what happens is it includes the endocervical area, which has this mucus producing glands, and they will be incarcerated in the scar. So what happens is the mucus secreting, so there will be the mucus secretion from this gland, and that entrapment of mucus, it will lead to the formation of inclusion cyst. Okay, so that will further increase the defect and increases the endometrial instability. Also, if we close the uterine layer, first layer in large bites and tight locking, it will also omit the innermost residual layer, so it will cause this inverted V-shaped pockets for this nick development, and also it will result in ischemia of the scar, which will cause poor wound healing. So, of all associated factors, what they have found is the locking sutures which cause ischemia is the most important or single greatest risk factor for this defect development. Okay, so locking suture, tight locking suture, it will result in ischemia, and this is the most important factor for this cesarean scar defect. Also, larger nicks or larger defects, they are associated with dense adhesions, which can be detected at laparoscopic assessment. So what happens most of the time, we can see that sometimes this lower uterine segment after cesarean section gets adhered to the either bladder or to the anterior abdominal wall. So it will cause the traction in opposite, so this adhesions will cause traction in the direction of anterior abdominal wall, while the healing process, that is retracting scar, it causes the forces in opposite direction of that adhesions. So that will responsible for the larger defect development, and also causes the retroversion of the uterus. So it will again together it will give rise to larger defect. So adhesion formations is depend upon the inadequate hemostasis, infection, tissue ischemia, tissue devascularization, and tissue manipulation. So all these factors promote the adhesion formation, and it is also responsible factor for the larger defects. So what is the most important preventing factor in this defect development is the double layer non-locking uterine sutures. Okay. So till now what they have found is what can prevent this formation of this cesarean nick or defect is the double layer non-locking uterine sutures during the cesarean section. So what they have found out in different studies is residual myometrial thickness. It decreases by 1.26 millimeter if you close the layer in single layer. If you close the incision in single layer as opposed to the double layer. So the residual myometrial thickness will be decreased if you do it in the single layer closure. Also, this healing ratio. Healing ratio means residual myometrial thickness. That means the myometrium over the scar area as compared to the myometrium in the adjacent uterus tissue or adjacent uterine tissue. So that ratio is also reduced when you close the uterine incision in single layer. Also, this nick prevalence is increased when the decidua was excluded in the uterine closure, and dysmenorrhea is more common after single layer closure. Okay, so all these factors, this suggests us that double layer non-locking closure is a more beneficial technique for the cesarean section. So it depends upon the number of cesarean section, as I told you. So the prevalence of the scar defect is 61% after one section, 81% after two sections, and 100% after three cesarean sections. Also, median distance between the deficient scar, so the scar defect and internal os, it was found out in one study, it was 0 millimeter, and the range is 0 to 26 millimeters. That means it indicates that lower level of uterine incision is responsible for more scar defects. While you are diagnosing this cesarean neck or scar defect, there is lack of consistency in the diagnostic criteria. So again, the prevalence in different studies has been varied because of there is no consistency in the diagnostic criteria. There is no proper proposed diagnostic criteria. So what they have found out, if using transvaginal USG, the prevalence of cesarean neck is 24 to 70%. Well, if they use this contrast enhanced sonohystrography or gel instillation sonohystrography, the prevalence of CS scar defect is 56 to 84%. And what they have found out is sonohystrography or gel instillation sonohystrography. This is the gold standard for diagnosis of cesarean neck. While they have decided that when they have compared different diagnostic criteria, so when they have taken the limit as 3 millimeter, so when the 3 millimeter threshold is used for the diagnosis of neck, what they have found that there was no increase in the thickness when with the passage of time, but with passage of time after cesarean section, there is a reduction in the thickness of residual myometrium and adjacent myometrium. So what we think that after the involution and after the healing period, after 1 or 2 years, the actually the myometrial thickness may increase. But what they have found out in studies is this is the decrease in the thickness which happens over a period of time in this scar defect. So how these patients present with this scar defect? So most common symptoms is postmenstrual spotting or prolonged menstruation. Most of the women, they will be asymptomatic. Some reports gynecological symptoms like postmenstrual spotting, erratic or prolonged menstruation, continuous brown discharge, chronic pelvic pain, and secondary infertility. The patients who have this residual myometrial thickness less than 50% of adjacent myometrium, they are more likely to be symptomatic. So what depends, symptoms are dependent upon the thickness of the residual myometrium. That means myometrial thickness over the scar defect. It defines whether the patient will be symptomatic or not. Okay, so postmenstrual spotting is present in almost 34% of women who have this neck or defect is diagnosed by sonohystrography. Larger defects, they are associated with more symptoms and also associated with pain. Okay, so larger defect, more symptoms and more pain. Usually what happens is there will be troublesome bleeding, but it will not be life-threatening. But sometimes neovascularization can occur surrounding the neck and it will be permanently affected, and sometimes there is severe or torrential recurrent bleeding can occur from this abnormal blood vessels. The larger necks, they are present with pain and they are usually complicated by the anterior adhesions to the bladder and abdominal wall. So as I told you, these adhesions, anterior adhesions, they give the action in the opposite direction and they are responsible for the larger defects. Again, subfertility can be a symptom of this cesarean scar defect because of scarring and distortion of anterior isthmus, which leads to because of this collection of menstrual debris in the neck, altered mucus production and impaired sperm's passage. So all these things, they will contribute to the subfertility. This retention of fluid, this acts like a fluid in hydrosalpingo. So it may be toxic to the embryo also, and it will be interfere with sperm receptivity also. So these are the factors which contributes for the subfertility in case of cesarean scar defect. Also adhesions, dense adhesions which are associated with larger defects and morbid adherence of uterus to anterior abdominal anterior abdominal wall causes distortion of the vaginal anatomy. Cervix is pulled high up, which will result in chronic pelvic pain, dyspareunia, and subfertility. So all these things, again, they are contributory to the subfertility. But till now, there are studies, there are not so many studies whether they have found out whether this resection of the cesarean scar defect will improve the fertility or not. Okay, so whether these surgeries will improve the fertility, still it requires further studies to recommend the surgery for the treatment of subfertility. Now, what are the diagnostic criteria and what are the diagnostic tests? These are proposed for this cesarean defect diagnosis. So, as I told you, gold standard, it is a gel instillation sonohistography, which has a higher detection rate as compared to the transvaginal ultrasound. But TVS it is the most commonly available and most easily accessible. So it is the first method of diagnosis. Remember, so first diagnostic tool is the TVS, while gold standard is sonohistography or gel instillation sonohistography. Okay, TVS, it has been shown to detect cesarean defects in 50% of women with previous cesarean section. According to the European NIC task force, what they have defined this NIC as cesarean section with depth of at least 2 millimeters. So this depth should be at least 2 millimeters for the diagnosis of a NIC. So whatever the diagnostic modality, whether it is ultrasound or whether it is a gel instillation sonography, the measurements, there are specified measurements that should be taken whenever you are diagnosing a cesarean scar defect. While what is the difference between this gel instillation sonography and routine TVS is, why GIS is considered as gold standard? Because usually what happens in presence of fluid. So in presence of fluid in the endometrial cavity, what happens is same diagnostic sensitivity is achieved with sonohistography and transvaginal ultrasound. So what they have proposed that with transvaginal ultrasound, if you do between 7 to 14 days of cycle, it gives similar sensitivity as that of GIS for diagnosis of this cesarean NIC because of presence of fluid. Okay, and this fluid will be present in mid follicular phase. So if you do the ultrasound between 7 to 14 days, the sensitivity of ultrasound and this sonohistography will be similar. Now, whenever you diagnose any cesarean NIC, okay, or any defect, what are the measurements that you should take? That is the most important. So basically the diagnostic criteria is depth should be of at least 2 millimeter. Okay, so this depth, it should be at least of 2 millimeter to diagnose the defect or to call it as a cesarean scar defect or NIC. And what are the measurements you should be taken? So it is the length, depth, okay, residual myometrial thickness. So you can see this is a residual myometrial thickness here, adjacent myometrial thickness, and then distance from the UV fold and distance from the external os. These are the measurements that should be usually taken. Why this measurement should be taken? Because if you have to plan a surgery, you should be knowing which modality should be used and how much resection should be done. So for that, this measurement should be done. So depth is measured starting from uterine cavity to the apex of NIC. Residual myometrium is measured from apex of NIC to the uterine serosa, and it is the crucial in planning surgery. Transverse plane width is measured. If any branches to this defect are present, each branch, the measurement should be taken specifically. Okay, so every branch should be measured in all these measurements again. Also, as I told you, we have to measure the distance from UV fold and from the external os also for planning the appropriate route of surgery, whether it is a hysteroscope or laparoscope. Also, other diagnostic modalities, while you are doing any hysteroscopy or laparoscopy, you can identify this cesarean NICs. So on hysteroscopy, the appearance of NIC will be either concavities in the isthmus with a prominent distal ridge, breach in the mucosa of varying depths, lateral branches, presence of abnormal vascular patterns, and presence of cyst-like or polypoid structures. So these are the hysteroscopic appearance. Laparoscopy usually shows ballooning of lower segment, which is usually associated with dense adhesions to the either bladder or anterior abdominal wall. So these should be, you should always remember while you are doing any hysteroscopy or laparoscopy for any gynecological symptoms. So here you can see a hysteroscopic view of this cesarean NIC or cesarean defect. So sometimes synecdoche are seen in the cavity, okay? And along with that, here you can see this is the distal ridge. Okay, this is the distal ridge on the hysteroscopic appearance. And after treatment of this roller bowel ablation, resection and roller ball coagulation, you can see the defect is closed. So how you are going to manage this cesarean defect or cesarean neck? So if the patient is presenting with only menstrual symptoms, first management should be always medical, okay? Either with hormonal treatment, so either it can be levonorgestrel intrauterine, so LNG-IUS, or endometrial ablation with roller ball ablation. It is the when the fertility is not required, these are the plan of management. Either can be with hormonal treatment or with Mirena or ablation, endometrial ablation. These are the treatment of choice for menstrual complaints. Surgery is indicated in case of significant menstrual symptoms which are not responding to medical treatment or where subfertility is suspected because of this presence of cesarean scar defect. Okay, so these are the indications for surgeries. Now, what are the surgeries should be offered for this cesarean neck? So it can be either hysteroscopic resection of distal ridge or with or without the knee ablation or laparoscopic repair, that is resection and the repair which is performed under hysteroscopic guidance. So minimal access surgical interventions for menstrual symptoms only, it should be applied in research setting. So only for menstrual symptoms, surgery is not routinely advocated. It should be done only in research settings. So hysteroscopic resection, it should be performed with 9 mm resectoscope after cervical dilatation and instillation of blue dye into the bladder to see any injuries. Also, what you have to do is you are going to resect only distal rim of the neck just above the internal os. Proximal ridge or proximal rim is not resected because it increases the risk of cervical incompetence. Complications of hysteroscopy surgery is bladder injury. So it should not be done when the residual myometrial thickness is less than 3 mm. So hysteroscopy is avoided when the residual myometrial thickness is less than 3 mm, where the choice of surgery will be laparoscopic resection. So laparoscopic resection, it should be done under hysteroscopic guidance with monopolar hook. The neck is opened and excised with routine or cold scissors, and then repair is performed in 2 layers. Interrupted layer. So first layer will be interrupted sutures with vicryl, followed by continuous inverting suture as per usual what we do for cesarean section. But it should be non-locking. Whatever the studies are available, what the evidence shows is neck surgery is very effective, but in absence of good quality direct comparison studies, it is not recommended as first line option for neck related menstrual symptoms. So as I told you, for menstrual symptom, it should not be done routinely. Okay. Now, whenever the neck is done, how to choose the route is, so it depends upon the RMT or residual myometrial thickness. So when RMT is less than 3 mm, the approach should be laparoscopic. When the RMT is more than 3 mm, the approach should be hysteroscopic resection. The neck surgery is usually associated with risk also, so it should be performed only by experienced surgeons. So this is regarding the cesarean neck, and this is the TOG question. This is the strategy question in this talk. So I think this is the very easy question. You can just type in your answer box or chat box. Yes, Ria, neck is the cesarean scar defect. Yeah, it is a double layer non-locking sutures. So thank you today for attending. Tomorrow we will do this WHO anovulation talk. WHO type 1 anovulation. I think it has been remained from this July 2020. That is the only one talk which has remained from that July 2020. So we will do it tomorrow. So bye for now.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.